in from the waiting room. All right, well, good morning, everyone, and welcome back as we continue the Governor's Opioid Response webinar series. My name is Madison Brassa, and I am the SUD Program Manager and Backup State Opioid Treatment Authority, also known as the SOTA, out of the Office of Behavioral Health. Catherine Kutu is the SOTA for the state of Maine. Thank you for allowing me to moderate today's webinar. Before we begin, I'd like to highlight some of our previous efforts along with current initiatives and introduce our presenters. We took a break last month after having a very successful in-person summit in July. The Governor's 4th Annual Opioid Response Summit had over 1,200 attendees at the Cross Insurance Center in Bangor on July 11th. There were over 200 people who watched the live stream, including addresses registered in Texas, Rhode Island, Connecticut, Pennsylvania, New Hampshire, and Maine. Some of these locations that streamed in the event had multiple viewers, including one correctional facility. We had great keynote speakers, including state and federal delegates, a nationally recognized author, and Governor Janet Mills. There were 33 breakout sessions with an impressive list of speakers and topics. These topics were organized around the 4 pillars from Maine's Opioid Response Strategic Action Plan, which included prevention, treatment, harm reduction, and recovery support. The summit also featured close to 40 voices of recovery who spoke before the keynotes and breakout sessions. We had volunteers from OBH, OMS, CDC, OCFS, and other departments within the state. We also had volunteers from Bangor Area Recovery Network, Journey Magazine, Maine Prisoner Reentry Network, Macaulay House, Eastern Maine Development Corporation, UMaine, AdCare, PTTC, and Maine Responds. A huge shout out to all of the volunteers, participants, and organizations for making this such a special event. I want to make everyone aware that September is National Recovery Month. Recovery Month celebrates the gains made by those in recovery. This observance reinforces the positive message that behavioral health is essential to overall health. Prevention works, treatment is effective, and people can and do recover. We strongly encourage you to check in with your local recovery center to see the various events that will be occurring in recognition of Recovery Month. I will shortly post in the comments the link to our 17 recovery centers dispersed across the state. We have a great presentation today with the focus on the approaches to substance use disorder with methadone. Methadone treatment has been constantly evaluated since its development in 1964 and is considered a safe and effective method for treating opioid use disorder. This treatment modality has been available in Maine for over 2 decades, with 12 opioid treatment programs now open. It is the medication for opioid treatment disorder treatment with the most experience to date. There have been 2 new opioid treatment programs that have recently opened in the state, representing the first new clinics in over a decade. At this time, I'd like to introduce Jacqueline Sear and Peter Morris. Jacqueline is a family nurse practitioner at Northern Light Acadia Hospital in their adult ambulatory clinic and medication-assisted recovery program. Her duties include serving as the primary provider of medications for opioid use disorder at Acadia, where she is also Director of Substance Use Services. Jackie earned her BSN in nursing from Husson University in 1995, and in 2007, she completed her training as a family nurse practitioner, also at Husson. She began her career with Northern Light Acadia Hospital in 1998, and since that time has held a variety of leadership positions with the organization. Jackie is a strong advocate for patient-centered care and approaches her work from a biopsychosocial, spiritual perspective. Peter Morris is the co-founder and CEO of Everest Recovery Centers. Peter was most recently the president of the Comprehensive Treatment Centers Group for Acadia Healthcare. In this role, Mr. Morris oversaw the day-to-day operations of 127 clinics in 32 states, which treated roughly 63,000 individuals with opioid use disorder daily. Prior to this, he held positions as regional vice president of the New England region, which had 21 treatment facilities, and the East region, which had 31 clinics. Mr. Morris was previously with Discovery House and Smart Management, Inc., holding positions as the Chief Operating Officer, Vice President of Finance, Director of Finance, and Staff Accountant. Mr. Morris obtained his Bachelor of Science in Business Administration degree from Bryant University, formerly known as Bryant College, in Smithfield, Rhode Island. He has 29 years of experience in the opioid use disorder treatment industry. In 2017, Mr. Morris was an invited guest to the White House Opioid Roundtable. In 2013 and 2015, he presented at the ATOD conference and was a panelist at the SAMHSA conference in 2013. Mr. Morris has also served as the NABH Addiction Committee. Just a reminder that if you do have any questions during the webinar, please share them in the Q&A box as opposed to the chat. We will try to answer all of the questions during this webinar. Any questions that we can't get to, we will post answers and update them to the Summit webpage on a later date. Gordon Smith is with us today, and he will introduce the October webinar series topic at the conclusion of today's discussion. As always, please keep a lookout for AdCare to promote that event in the near future. Without further ado, I'll turn it over to Peter.
Thank you, Madison. Good morning, everyone. Can you hear me fine?
Yes, we can.
All right, I was having some audio issues. First off, thank you to Governor Mills for having these events. As Madison pointed out, the annual summit was a tremendous success. I was there on July 11th and was pretty surprised by the attendance of 1,200 plus folks. So thanks to Gordon Smith, Catherine Kutu, Josh Miller for the invite, and also thank you for Madison hosting today, as well as Lorana from AdCare. Before I go into my slide presentation, myself and Jackie we've collaborated offline, and we're going to take an approach where I'm going to cover more of the history, industry at a national and state level, and also some new initiatives going on with methadone treatment. And Jackie will really focus on the medical component. So at this time, I will bring my slideshow up.
Pete, we do have someone in the Q&A just saying that they are having a little bit of a hard time hearing you. So just to let you know.
Okay. So as Madison already covered, I won't go through each bullet, but just a brief introduction. My story of getting into this field back in 1993 when I graduated business school, and my focus was really going to be on being an accountant. I got connected to Discovery House in Rhode Island back in 1993, and I quickly fell in love and had a passion for this business. When I started, didn't know what methadone was, didn't know what really opioid use disorder was. And as I grew within the company and the company grew, it just became something I became very passionate about. I was visiting clinics around the country and seeing the impact we were having on patients' lives, and seeing a lot of folks who were my age or younger at the time when I was in my 20s, coming in with their parents, and it was a very low point for them in their lives, and watching them recover and get better was certainly rewarding and fulfilling, and it's why I continued my journey in this field. Once Discovery House was acquired by Arcadia Healthcare back in 2015, I worked for Arcadia for roughly 4 years, and at that point in time, I was really kind of really contemplating what I wanted to do the next 10 years of my life, and really decided to put my past experiences together. I got back, so to speak, with the old gang. There's myself and 4 of my former colleagues from Discovery House got back together, and really our focus is to help local communities fight this epidemic. And I really want to focus on Everest Recovery being a place that I'd want to send a family member of mine if they needed help. Everest Recovery Centers, again, we're an opioid treatment program. We currently have one site in Saco, Maine, with 2 others under development in the New England area. An opioid treatment program, as defined, is basically a program where a practitioner engaged in opioid treatment of individuals with an opioid agonist medication. Our mission is pretty simple. We're a startup run by seasoned veterans, as I noted earlier, and our mission is to provide comprehensive services to persons affected by this addiction. Our focus really is to help people rebuild their self-esteem, reestablish their roles with their family through our services. Just a couple of quotes I wanted to point out, and I've stumbled upon these over my time in this industry. Addiction is a chronic illness, and it's accompanied by significant changes in the brain. Addiction, does not occur because of moral weakness or lack of willpower or unwillingness to stop. The first time, I've dealt through, whether it's through zoning meetings or talking to various stakeholders at a legislative level, it's really looked at as that people making a choice, and certainly they voluntarily control the first time they experiment with either alcohol or drugs. But once that begins to take over, it changes their brain consistency, and it really becomes an issue that they can't control. They need medication or other services to help with this disease. There's currently 3 FDA-approved medications to treat folks with opioid use disorder. I won't read the slide verbatim. Methadone is the one that's been around the longest for 50+ years. It's currently for opioid use disorder. Addiction treatment can only be prescribed out of OTPs. It's had a lot of research, it's highly regulated, and it is considered the gold standard of treating opioid dependence. It's an excellent medication when used properly, with much higher retention rates, and it's certainly complicated. It's a very effective medication. However, when not used properly, can also create overdose and have other negative interactions. Buprenorphine, a Schedule 3 controlled substance, has been around, FDA approved in 2002. This is prescribed by physicians in the office setting, and some OTPs also provide this form of medication. Similar to methadone, it eliminates the withdrawal symptoms and relieves the drug cravings from heroin and prescription opioid medication. There has been a high diversion rate in the physician office setting with buprenorphine, as its patients are getting scripts and going to their local pharmacy to receive medication. The third medication is naltrexone. This is something that, even with my personal experience, we've used very little. It does require a patient to be on the withdrawal stage, and it needs patients to be highly motivated. So it's been found to work better when folks have been abstinent when they have been in, whether it's incarcerated or in a inpatient facility. Medication-assisted treatment is this is going to be critical, and Jackie's going to really hone in more on this on her slide. But it's really critical that medication-assisted treatment is a combination of counseling and behavioral therapies. It's simply not medication alone. Medication alone is not MAT. The medication stabilizes the patient, and it's critical in the first week to 2 weeks, 20 days, first 21 days of treatment, that a person be brought up to a stabilized dose. Certainly when they're in that induction phase and they're being stabilized, it's hard to have the patient focus on anything but getting stabilized and feeling physically better. One of the strategies we use at Everest Recovery, as an example, is the intake process. And when I think back 15, 20 years ago, the intake process would be something that would take roughly 3 to 4 hours. A patient filling out a lot of paperwork, signing a lot of waivers, signing a lot of consent forms. And what we've done over the years is try to spread out that 3 to 4 hour intake process over the first several weeks of treatment. and really just focus on getting the patient in the door, getting them on their medication, and getting them stabilized. Studies have found folks on MAT are 75% likely to have addiction-related deaths. Medication-assisted treatment, again, a whole host of things. It really decreases illicit opiate use, criminal activity, allows folks to regain connections with their family and their jobs, etc. However, it is greatly underutilized. It's still at this stage, there's a lot of folks who have opioid use disorder out there who aren't getting treatment. Just a couple of outcomes I noted, NIH, basically methadone maintenance coupled with relevant social, medical, and psychological services has the highest probability of being the most effective for all treatments. 90% of patients receiving treatment at an OTP for more than 1 year test negative for opioids on their most recent drug screen. Just a couple of industry level, at the national level, there are approximately 1,900 OTPs operating in 49 states, the District of Columbia, Puerto Rico, and the Virgin Islands. And notably, to this day, there's still one state that does not allow OTPs, and that's Wyoming. OTPs have certainly expanded over the last 5 years. 5 years ago, there was around 1,500 clinics, and now there's 1,900, as I stated. They have, one of the challenges of expanding OTPs is certainly there's still a lot of stigma attached to it, and there's a lot of local zoning regulations and planning boards and others that we have to go in front of. And I will say, in my experience so far with Everest, at the Saco site, and also with the two other sites I have under development in the New England area, it's really changed. They've been very welcome. They understand that this is a service that is needed in their community. However, there's still some stigma out there. And roughly there's about 550 to 600,000 patients who are receiving treatment via OTPs. And about 6-7 years ago, that was around 400,000. Just a visual, slide's more of a visual, it's a little blurry, I apologize. But it kind of gives you at least from a visual standpoint, the 12 locations, the 12 OTPs in Maine. As you can see, they're heavily concentrated along the 295 interstates. You do have Calais on the middle right, and you have Presque Isle, which is one of the 2 new clinics that Madison mentioned earlier that opened in the last 12 months. So you can see that large gap in the state and the rural areas. And I'll speak more in a few minutes about some of the tactics and some of the things that DEA and the industry is doing to allow treatment to get to these areas. This is just a quick list of the 12 providers in Maine, and there's been a lot of consolidation, acquisition in the industry, so I just use the parent name, but Acadia Healthcare has 5 sites. Baymark Health Services, 2 sites, CAP Quality Care, 1 in Westbrook, Everest Recovery Centers down in Saco, and then New Seasons with their 2 sites, and Northern Light, which is Jackie's facilities up in Bangor. A couple of new initiatives I want to talk about with the DEA. They published guidelines on June of 2021, and there's really the first initiative is mobile vans, and they've been around. However, there haven't been any new ones approved since I think it was around the late 80s, early 90s in Massachusetts. They had one approved. DEA has been very careful with it, I would just say, over the last 15, 20 years of really issuing new guidance. ATOD, the National Trade Organization, worked closely with them in SAMHSA, and they published these new regulations. But really 3 major uses for the vans. One is really just getting in the van, driving out to a remote area, and in a parking lot or another medical facility, and having patients drive to that area to receive their treatment. The second application is really the vans being used to drive to the correction systems. So same concept. The mobile van pulls up, patients get the medication, and the van goes back to the home clinic. And the third application, similar, is really using it for residential settings, recovery homes, skilled nursing facilities, and nursing homes. Another initiative in this publication on June of 2021 from DEA is medication units. Medication units really are, they're really a satellite, if you can, that's the good way to look at it. They're satellites of an existing OTP. They utilize their bricks and mortar. They're out there. They may be 20, 30, 40 miles from the existing OTP, and they provide the medication, and the clinical services and medical services for the most part are handled by the home clinic. And that can be done either by telehealth or trips to the home clinic on a maybe a monthly basis or twice a month basis based on the person's treatment plan. And certainly this is a lot better than the patient driving every single day. It could be 2 hours round trip to the home OTP. Another initiative that's in this in these regulations really is the telehealth services. Really, with COVID, that really pushed us to this kind of initiative. However, what we found in the OTPs, some of the patients had struggles with technology and visual two-way exchange. So it's something, and most of it was done through audio over the phone. So this experience is really having the industry really look at how we can really incorporate telehealth into the updated OTP policies. So ATOD and others are working with SAMHSA to see what we can do in this area. Challenges, every industry, every business has their challenges, and I will say, when I think of the challenges facing OTPs, I think most of my colleagues in the other, 12 clinics in Maine would agree. I would say probably the biggest challenge right now is workforce. It's really very challenging, and specifically in the clinical area. Getting clinicians, LADCs, CADCs, and other folks has been very challenging. Funding continues to be a challenge. It's expanded tremendously. There's a lot of funding out there at the national and state level. However, when sometimes you look at the fine print, some of the funding, the grants, the federal grants, private for-profit or for-profit clinics are not allowed to apply for them. So it's something we've made great strides, but funding is still an issue inside the industry. Educating stakeholders around the components of MAT, medication and clinical, that is an ongoing battle, an ongoing process. And I shouldn't even use the word battle, but it's something that I enjoy doing, getting in front of folks who may not quite know what OTPs are or what medication-assisted treatment is, and educating them on the benefits and the outcomes and the science behind it. And lastly, stigma is still an issue for folks with opioid use disorder. And that's, again, I've seen a lot of improvement, but stigma can be from a lot of different areas, a lot of different stakeholders, sometimes even inside the medical community itself. And it's something that we as the OTPs and as a large industry, we're going to keep on educating the public on this stigma and kind of breaking through that stigma. And with that, I will turn it back to Madison, who I believe will hand it off to Jackie. Thank you very much, folks.
Thank you, Peter. Really appreciate that. Jackie, you are up. And just as a reminder to folks, if you do have any questions, please put those questions in the Q&A box. And Jackie, I think it's all yours.
Great. Thank you so much, Madison. Give me just a second to get this going. Peter, great job. Can you see that?
No, Peter's still, oh, there we go. Now try it again, Jackie.
Okay. All right, guys. How about now?
Nope, still not seeing it.
Madison.
It's okay.
All right, guys, bear with us here just a second longer.
Jackie, if you think I have the most up-to-date one, I could share my screen and you can just tell me when to go to the next slide if that works for you.
That would be helpful. Yes, if you don't mind taking it, I can't seem to get connected.
All right, just give me one sec. Sorry, everyone, there's some technical difficulties today.
So anybody on the call, just so you all know, will not be surprised that there's technical difficulty on me. So I apologize so much to the group for that.
No,
Goes to show my specialty is inpatient care.
all right, I think I have it up here. All right, can everyone see my screen now? Jackie, can you see it?
Thank you.
All right, take it away.
Okay, thanks. So thank you, Peter, very much for that presentation. And I'm excited because you covered so much that I get to speak a little bit more on the nuts and bolts of treatment. So that's great. I'm blessed to be a provider here at Northern Lights and be able to provide all of those agents that are available for the treatment of opioid use disorder. I'm really encouraged by the barriers that we are seeing coming down around treatment. And I am looking forward to seeing where we're going. But as we move forward in breaking down those barriers, I'm hopeful that we don't close the doors on other therapeutic tools as we move forward. My objective today will be to provide a brief overview of one of these. Whoops, can we change the slide, Maddie? There we go. One of these treatment modalities in the form of methadone. I'll build upon what Peter has already presented. I'll be highlighting the importance of comprehensive care and connection, talking about the multidisciplinary approach with patient first, patient-centered, and aiming to really individualize care and wrap it around the individual in need. Next slide. So as Peter had already shared about methadone, it's important to know that methadone itself is an opioid. It's a Schedule II medication used for the treatment of opioid use disorder. It bonds to the same receptors in the brain as other opiates, but it acts differently in this case. It's delivered within the Opioid Treatment Program. The purpose is to increase functionality and quality of the individual needing services, to reduce withdrawal symptoms and cravings. It is a life-saving measure. It's delivered on a daily dosing schedule here in the clinics, but over time, with stability and recovery, patients have the ability to gain access to take-home medications. We're always going to be looking for and towards the least restrictive form of treatment. Methadone is known as the gold standard of treatment within MOUD. Next slide. So just briefly, as we've already kind of covered the benefits and risks, it's important to know that one of the greatest benefits is to an individual who's struggling with opioid use disorder. When they enter into treatment, if the patient is coming from buprenorphine to methadone treatment, they can do that safely and without any having to be in any form of active withdrawal. That is not the case if the patient is going to be transitioning from methadone to buprenorphine. Greatest benefit is providing relief to the withdrawal symptoms that they're experiencing and preventing further, reducing cravings. It has a high efficacy. Risks within treatment, there is the chance of possible overdose, misuse, dependence, hyperalgesia, which is that abnormally heightened sense of pain or sensitivity to pain, and cardiac arrhythmias, which is an irregular heartbeat. Next slide. So who is methadone appropriate for? It can be a first option for patients who have done well on methadone in the past. We're going to be looking at how long the patient has been using, what they've been using, the amount, the frequency, and the route of which they've been using. Patients who don't want to or have not had benefit from buprenorphine in the past, or for patients who have been inducted into buprenorphine and they've been walking on that journey but haven't been able to achieve the success and recovery with that agent that they had hoped. Next slide, please. So diagnostic evaluation, Peter did touch on this a little bit. This is a huge part of individuals getting into treatment. The diagnostic evaluation, here at Acadia, we utilize our master's paired clinicians that do a comprehensive psychiatric evaluation, which affords them then the ability not only for the diagnostic component for our addiction care program, but if they were to need to receive services elsewhere, in our system. Part of the medical workup is noted here. Within that diagnostic evaluation, the determination of the OUD disorder with severity is obtained during that time. All of that information is brought forward to the provider. The provider is very involved in that process. And then the provider will meet with the patient. And when the determination of what course of care an individual is going to enter into, it's really important. It's the responsibility of the provider to make sure that the patient is aware of all of their treatment options. That way, the patient is truly making an informed decision in their care. Next slide. So methadone has a narrow therapeutic window. It's a fine line between too much and too little. There's such a wide variation in how this medication is absorbed, metabolized, and responded to by each individual, and it's based on their body chemistry and life event piece that goes with that. All of this is important to take into consideration to prevent the patient from receiving a toxic or an ineffective dose. It can take 3 to 5 days for the individual to feel the full effect of each increase. And the goal here is really to stabilize, to replace the illicit substance use with safe, monitored dosing that allows for them to move forward in the next phase of their healing process. When we are noticing with fentanyl's presence and the illicit supply currently, that stabilization is happening closer within the 80 to 100 range, whereas before we were seeing it more in the 60 to 120. That's not to say that there aren't doses higher or lower. It's just where we seem to be seeing it. Be interesting how that changes as we move forward. Next slide, please. So what is fentanyl? It's a synthetic opioid also. It's 50 times more potent than morphine. I won't read the slide to you, but just note our region of red, and the fact that there were overdose deaths in the United States exceeded 100,000 in a 12-month period. That was from May of 2020 to April of 21. Next slide, please. Because of this, it is so important that people know how to recognize the signs of overdose and what to do about it. To know what Narcan is, it reverses the effects of opioids. It's a life-saving measure. It is strongly encouraged that people seek medical care in the event that Narcan is needed to be used. And it's best practice that Narcan be provided in conjunction with MOUD treatment. Also, any safe use practices, harm reduction practices are so important for individuals to be aware of. We must remember that opioid use disorder and addiction does not discriminate. Whatever your belief of what someone who lives with and experiences substance use disorders looks like, we need you to throw it out the window. You never know. It could be any single one of us. Next slide, please. So addiction, that's the tip of the iceberg. That's what we can see. We don't know what's going on down there underneath that water line. And once individuals get to the point of stabilization within their treatment with whichever agent they choose to use, this is where the hard work begins. So now that the individual that was brave enough and strong enough and let themselves be vulnerable enough to go through this process, what comes next? Next slide, please. This is where we have to identify that methadone is so much more than a medication. This is the hard stuff. This is the gold. Methadone treatment is about treating the whole person. It's a treatment philosophy. It's patient-centered, it's trauma-informed, it's see the whole person, mind, body, spirit, it's all connected. When someone steps into treatment in the beginning, oftentimes the medication is that much of their recovery. But as they start feeling better and things start stabilizing, the medication starts becoming this important and everything else becomes that important. It's that flip-flopping. The patient-centered care piece is about focusing on the individual and the problem at hand, but not seeing them as their diagnosis. And the trauma-informed approach is about recognizing that more likely than not, that individual has a trauma history. So stepping into care, and quite frankly, stepping into any interaction that we have, because we're just humans taking care of humans, is about utilizing those 6 principles: safety, trustworthiness and transparency, peer support, collaboration, empowerment, voice, choice, and cultural issues. Next slide, please. So coming at it with an interdisciplinary or multidisciplinary approach, recognizing that the starting point is the person in recovery. They're the head of the team, right? We're working for them and with them. And that's also where that trauma-informed care approach comes in, because it's not always rainbows and sunshine, and we have to be able to have those hard conversations. But if someone knows that you're coming from a genuine place of caring and wanting to help, we may not like each other's message, but if we understand the why in a respectful manner, it makes it that much easier. This is also a place where sometimes we recognize that not everybody's meant to be on each other's paths forever. And that's okay too. If someone feels that a program's not right, or however you want to look at that, the point is the person walked through the door, they got started, and now we can help them get connected with other treatment entities. And we're really blessed here in Maine with how many people are stepping up and doing the work and supporting. So it's really about balance and facilitating recovery and focused care, being non-punitive and setting boundaries. We have to learn how to work within the structure, within the treatment programs, but also making it as individualized as possible. I want to really focus on wrapping around that patient and that holistic approach and collaborative that happens. By doing this, it increases the number of safe people and resources that the individual has in their recovery community. The use of master's level clinicians, the LCSWs and the LCPCs, one of the really significant benefits of having that in place within an OTP is that they're able to deliver a level of therapy that the individual may not be able to access due to limited to or no insurance. So the co-occurring disease processes that happen oftentimes can really be targeted more in depth in that moment. We're blessed with CADCs and LADCs that provide counseling specific to substance use disorder. And this is just the tip of the iceberg on what they do, but they do things such as helping develop coping skills, networking with recovery communities, relapse prevention, and so much more. The peer supports and recovery coaches, oh boy, so important. And I definitely don't have the time allotment to dive into that and do it justice like I think it needs. But I did want to share a quote from one of our peer supports when I asked her, what is it to be a peer support? What does that look like when you're doing a group? What's it about? And she stated, a lot of people are missing what peer support does, which is just provide unconditional support for someone from someone who understands the lows and whose only role is to listen, validate, and connect. Powerful, huge, and so important. In addition to those roles and the roles in which these team members sit within is the availability of providing groups. So many topics are covered. We do peer support group, parents in recovery, co-occurring addictions, stimulant group with contingency management, safe use, disease process, phases of treatment, prevention of overdose, relapse prevention. And then in there also are other treatment modalities, CBT, EMDR, DBT. Highlighting case management as well. This is so important. If primary needs are not being met, then an individual cannot move forward in the healing process because the focus needs to be on something else. Primary care. Collaborations between OTP providers and primary care is huge. When patients begin to stabilize on methadone or buprenorphine, it is important to recognize that they are going to experience what it feels like in their body differently. And it is not unusual to see certain disease processes that they've been battling that were masked start to present themselves. And that can feel and look like withdrawal. And that is why it is so important to drill down and make sure we're treating the right thing and not just assuming that it is the opioid use disorder. Mental and emotional health, medication management, therapy, counseling, and addressing that underlying co-occurring. Recognizing with the co-occurring addictions, there's a lot that could be going on there. Addictions can jump from one to the other, or they could be co-occurring. So whether it be an eating disorder, it be alcohol, stimulants, any of those things. But here's the really wonderful thing. There are a lot of treatment options out there. It's not a one size fits all, and not everybody is meant to be on the same path. What's most important is making sure people get connected. Next slide, please. So knowing all the treatment options allows the person in recovery to make a fully informed decision with guidance from their multidisciplinary team. Control of the withdrawals and cravings allows for a focus on addressing the cause of the addiction and the healing to begin. Next slide, please. Some resources. If you need support, the numbers are here. Here at Northern Light Acadia Hospital, we have a multitude of services that are happening. Next slide, please. It's really important just to know what those resources are. There's so many great things happening in our state, top to bottom. None of us do this work alone. I'm here in Penobscot County area. We have the Barn, the Together Place, Health Equity Alliance, Bangor Public Health. We've got the Maine Moms Project that's happening all over. The recovery centers that Madison mentioned earlier, Sober Living Homes, AANA, Maine.gov's website is amazing. There's so many 11 other additional OTPs. Here at Acadia Addiction Care, we have IOP program, AST program, which is alcohol focused, but open to other substances of use as well. There's pathways to recovery for our adolescent population, grades 9 through 12. The eating disorder clinic for both adolescents and adults. Running out of time, I think, but on this, it's so important to note that we also have the intentional warm line, which is peer-to-peer recovery focus, and the call or text to 988 should anybody be in a space of needing help. Our access points are PCPs, offices, EDs, first responders, EAP, school counselors, pharmacists, and specialty practices. Really moving towards that no wrong door approach, and I did not coin that, but it truly is about shining the light and making conversations and questions around substance use and addictions commonplace. Thank you. every person who's stepping into the arena and this fight that we have on our hands when it comes to opioid use disorder and substance abuse and use. We are making strides in the right direction. We've come a long way. We've got a really long ways to go. Please don't forget the small wins, because it's those small wins that make the big wins, and none of us do this alone. Thank you, Madison.
Thank you, Jackie. Beautifully said. Thank you, Peter, as well, for being here today. Did great on time, Jackie. Didn't even need to give you your 1 minute. Oh, good. So we do have some time for some questions if we want to get to those. See, maybe Peter's already answering one of the questions, but one that came up during his presentation was, what is the longest retention of more than 1 year in the studies you referenced? So Peter, I don't know if you want to answer that.
Sure. So, based on my experiences, I'll answer that kind of 2 parts. The average length of stay for patients in the OTPs I've been involved in is roughly 15 to 16 months for each patient. However, there are patients, I've seen some who were 5+ years in treatment. So again, for some folks, it is a life-sustaining and lifelong form of treatment, just as folks who have cholesterol who use a statin, or who have diabetes and use an insulin. So it's really individualized, and each person is different.
Okay, thank you. We have another question. It says, can you address all-cause mortality for each medication option? I'm not sure who wants to take that one. And I think there's a follow-up in suicide mortality on that.
What was the question, Madison?
Sorry. It was, can you address all-cause mortality from each medication option and suicide mortality? We can come back to that one as well if we need to.
Unless Jackie has information on that, there's nothing there's not feedback I have right now.
All right. Yeah, we can get that one answered after. Okay. Thank you. Let me see. Another question that came in: how do the OTPs work with clients who are approved to use medical marijuana?
So within our clinic, we do have individuals who have medical marijuana. It is a question that has come up, and if Catherine's on the call, she could potentially help us with this, but it is one that's being looked into further. We don't always pull their ability to have take homes. It is definitely not an area that prevents someone from being part of our methadone treatment program or our Suboxone program at all. We provide a lot of education around it about both positive and negative effects.
Thank you. Let me see. Another question that has come in: is methadone an option in the incarcerated population in Maine?
Yes, it is. Looking at Peter and Catherine also in the future, we'll be speaking to this, I think, more so. So yes, currently there are individuals within the system that are incarcerated that are receiving methadone treatment. It does present some more challenges in some areas, but it is an area that we're looking into on how to better support.
I'll piggyback on that. We've met, me and my team met even recently as this week with DEA and getting clarification, because there is information in the publication that came out in June of 2021. So it's really us at this point, the jail staff transporting the patient to us, receiving their dose on site, and getting a take-home box with take-homes, and then they bring them back once a week. So we are working on the particulars that go into that right now at this point. But the jail, the staff at the jail, the transporting staff can't have a key to the lockbox. So the dispensary staff at our clinic has a key. The dispensary staff at the corrections facility has a key, and that's how the patients are treated right now.
Thank you. Another question coming in. It says, Jacqueline mentioned a dosing range of 60 to 100 milligrams being the most effective, but most dosing references and studies use 80 to 120 milligrams. It's the VA guidelines through SAMHSA as optimal dosing range, but that sometimes requires lower or higher, especially based on the individual factors like other medications, tolerance, etc. So the question is, what are the rules or dosing limits that you use when prescribing at your OTPs?
So regulations also originally supported the dosing from 60 to the 120. As I stated, we are showing that we are needing to go a little higher on that. And that's just a reference range. That's not for every individual. Our current range is up into the 160s. There are a few people that are higher than that. I was trying to get a average where most clinics are. There are a few that are above the 170 to mid 200 range, but for us, we are primarily in that 160 to the 160 range.
Thank you. Another question coming in. What would the cost be for an individual having to purchase their own methadone? I might have to answer that question afterwards, but that's okay.
Well, I mean, if they're asking what we have rates, we have different payers, we have Medicaid. We currently don't have Medicare, but Medicare covers, because we're still in our first year. But the self-pay, someone coming in for a week, getting the medication and all the services is $95 a week at our clinic. And I think that's pretty consistent with the majority of the other OTPs. So if that's the question, the self-pay fee is roughly $95 per week.
Thank you. It looks like we have a little bit of time left for some other questions. Clarifying question on the mortality question earlier. It was another way to ask my question is whether any of the medication options is associated with lower total cost savings associated with lower all-cause mortality rates. I don't know if that's helpful clarification for you all to answer that question. You might need to connect offline as well. No problem. Let me scroll down here. Let's see. Will any grant funding support sponsoring a client at a methadone clinic?
Yes. Yes, there are grant slots available within the Methadone Treatment Program. There's criteria to match for that. Here at Acadia, we're also able to have grant slots within our OHH, which is daily dosing buprenorphine, which patients can then move to scripting out of medicine. There's a question in here about whether or not we support MOUD only or only MAT, and whether or not I'm stating that therapy is required in order for treatment to be effective. So in today's talk, focusing on OTPs and the requirements of that and current structure, we very much do have therapy built into that. Some individuals, as they move through the stages of treatment, do progress, especially with the changes in regulations, of not needing to be a part of regular required counseling schedules. But that being said, we recognize that opioid use disorder, mental health, addictions, whatever that might be, poses their challenges. And at times, sometimes it's opportunistic with increased stress and whatnot. So we just really like to make sure that individuals are aware of what is out there and available, and to really work on that long-term recovery maintenance plan, no matter what level that they're in, and having that forward thinking. Not everybody is at the place where they're able to move through their course of recovery, no longer needing any form of medication-assisted treatment, but they can still lean into some of these non-medical therapeutic options. And that's really what the importance of the message is knowing what resources are, and that there's a lot of tools that can be used. And the more we inform folks, the better their plan can be to keep themselves and their family members safe. I hope that was helpful.
Yeah, definitely. Thank you so much. I think I will leave the last couple of minutes to Gordon. He just wanted to introduce the October event, but just wanted to thank you both so much for being here today and sharing all of your knowledge and all of your care towards this program as well. So thank you so much. Gordon, it's all you. Might be bad timing on my part. Sorry about that, Gordon.
No, the bad timing was on the part of the Attorney General who just called me, but we've taken care of that. Listen, thank you. And I want to thank you, Madison, and Peter and Jackie for your presentations. And we very much in the Mills administration support expansion of methadone, the expansion of all types of treatments, but because of the substantial increase in Maine care reimbursement, that really permitted the expansion of the 2 new clinics that we have, and with 2 more expected, as Peter said. And we support all forms of treatment, and there really hadn't been an expansion of the number of sites in at least 12 years. So we've been pleased with what we've seen, and we're going to continue to try to lower the barriers and some of the regulations that make it quite difficult for and duplicative regulations and overlapping regulations that are not always consistent. So we are working on all of that. But I'm really taking just a minute to announce our October 7th program. We'll also have a webinar on Friday, November 4th and Friday, December 2nd. But on October 7th, it's going to be a little different. We're going to have a listening session to receive input on our existing strategic action plan. And we updated the plan about a year and a half ago. And because of our increasing overdoses and all the changes in the drug supply, we know we have to update the plan continually. And so the first thing that's going to happen is anyone who attended the summit or these webinars is going to get a quick survey that takes about 10 minutes to provide some input into the plan. But we really thought we would dedicate one of these webinars to having an open discussion. I'll take just a few minutes at the beginning of the webinar to share the highlights of the plan, which, as most of you know, is based upon the pillars of prevention, treatment, harm reduction, and recovery support. And then we'll hear from all of you about where you think we fall short, where some things that we might need to add, delete, prioritize. That's what we'd really like to accomplish on Friday, October 7th at 11:30. So I think with that, I again thank everybody. Madison, your debut at the moderator role was terrific. Thank you. Thank you, Peter and Jackie, again. Thank you to AdCare and all the work they do, and Josh Miller, our project manager. So have a wonderful Labor Day, and thanks for joining us this morning.
Bye, everyone. Thank you.